Welcome to the Healthful Woman podcast. Today's Monday, June 15th, 2020. I'm very excited about our podcast today, Pediatric and Adolescent Gynecology, The Few and the Proud, with Dr. Gylynthia Trotman. I've had the pleasure of knowing Jolynthia since she was an OBGYN resident at Mount Sinai. When she completed her residency, Jolynthia went on to do a fellowship in Pediatric and Adolescent Gynecology, which is an uncommon but critically important subspecialty of gynecology. We talk about the field of pediatric and adolescent gynecology in general, who might need to see her, and what concerns or conditions she treats. We also discuss the joys and challenges of treating adolescents and the unique challenges she has working with children and adolescents for issues related to gynecology, sex, sexuality, and navigating all of that with their parents. It is a fascinating topic, and I'm sure you'll be able to tell right away how kind, thoughtful, and talented Jolynthia is. She is awesome. On Thursday, I will be talking with Dr. Stephanie Melka about the delivery of twins. Double the fun. I put these seemingly unconnected podcasts in the same week simply because Jolynthia and Stephanie were OBGYN residents together at Mount Sinai. Now that was a great class. Stephanie has become an expert in the vaginal delivery of twins, and in our podcast, we talk about how she helps women with twin pregnancies achieve a safe vaginal delivery, and why so few obstetricians nowadays are able or willing to deliver twins vaginally. Vaginal delivery of twins is one of my areas of clinical research, and I think you'll notice our extreme enthusiasm for the topic. Thank you for listening. Have a great day. Welcome to today's episode of Healthful Woman, a podcast designed to explore topics in women's health at all stages of life. I'm your host, Dr. Nathan Fox, an OBGYN and maternal fetal medicine specialist practicing in New York City. At Healthful Woman, I speak with leaders in the field to help you learn more about women's health, pregnancy, and wellness. We're here with Dr. Gylynthia Trotman, MD, MPH, who's an assistant professor of Obstetrics, Gynecology, and Reproductive Science, also an assistant professor in the Department of Pediatrics, because Jolynthia is a pediatric and adolescent gynecologist. Jolynthia, welcome to Healthful Woman.
Thank you. I'm honored to be here because you're one of my main mentors. So thank you. You are.
Oh, you're so sweet. So what Jolynthia is referring to the fact that when she was a resident at Mount Sinai, I was already an attending, which means several things. One of which is that I'm older than you, which makes me feel old. And Jolynthia was co-residents or like same year as Dr. Stephanie Melka. And we all go way back. And
best class ever.
Best class ever. Well, some would say. Jolynthia, tell us, who are you? Where are you from? What's your story? Introduce us to you.
My name is Gylynthia Trotman. That name came from a friend in my aunt's class, so I do not know where that name originated from. So that's the first question I typically get.
Okay.
So my aunt thought it was a cool name, so why not just use Jolynthia? So my mom was like, sounds great, so let's just do that. So I am originally from New York, born in Brooklyn, to a Caribbean family. So grew up half the time in Brooklyn and Trinidad and then Queens. So I'm a New Yorker through and through. Went to medical school at SUNY Downstate in Brooklyn. Came to Mount Sinai where I met Dr. Fox, Nady, and the other best class of 2012. After that, actually during residency, I realized that I really loved the adolescent population. That's the population I really wanted to take care of. So I kind of found my way through by doing different things. I wanted to be every kind of OBGYN at some point. I wanted to do family planning. I wanted to do Urogyn for one day. I never wanted to do GYN-onc. I wanted to do minimally invasive at some point, but realized it was more about the group of patients and really didn't have access to that group of patients. How do I get to this group that really drives me? So I reached out to my mentors, of which Nady is one of them, Kathy Chen, and I kind of stumbled upon pediatric and adolescent gynecology, and I'm like, yeah, this is it for me. These are the patients I want to talk to. I want to do that. I want to show up for them every single day. So that was my way into that, and now I'm here.
And how did you find yourself in medicine in the first place? How did you decide on medical school?
Medicine, actually, true story. So I spent pretty much most of my summers in the Caribbean growing up, and I would read the newspapers, and there would be all this devastation surrounding women in childbirth or women's health in general in the Caribbean. So there was one story in particular that really stood with me. I was 14 years years old, reading the newspaper, and there was a 21-year-old young woman who gave birth. Her baby died, and she had some significant comorbidities that were terrible. She almost lost her life as well. And in that article, they really talked about how many women were dying in childbirth. And this is in 1994. So we're not that old. So at that point, literally at the age of 14, I decided I want to be a doctor. I want to deliver these women in this facet to take care of them. So that is what drove me. So instead of saying I wanted to be a doctor and then I wanted to be an OBGYN, I just had blinders on. I wanted to be an OBGYN because I wanted to take care of women who were not being taken care of.
Wow, that's so interesting because most people, certainly most people at the age of 14 maybe don't think about their future and I want to be a doctor, but certainly to have that focus that you want to do OBGYN, most people even going through medical school don't realize it until at some point it just hits them. But you went in focused and driven.
Yeah, I was a little crazy because in medical school, truly, I think had I not had that vision, I would have not have done OBGYN. It was probably one of my most difficult rotations in med school. People just seemed really unhappy. Like, I don't want to do this. And my mentor, I'll never forget, I really had like a breakdown one day. Imagine being like, I want to be OBGYN. And you finally get to that rotation. You're thinking you'll be happy. And you're miserable, right? Mm-hmm. And the residents are miserable and the attendings are miserable. Everyone's miserable. So I say to my mentor, I'm like, I can't do this. No one's happy. I'm going to do women's health and internal medicine instead. And she said, no, it's not OBGYN. It's just the environment.
Right.
So
right.
I took that and I went with it and I still loved it at the end. It was just more of a culture shock, I thought I would be so happy doing it. And it's like, no, this is reality and the happiness comes really after. So
right. There definitely have been and there continue to be a lot of people in OBGYN who, as you said, are unhappy doing it. I think that's true with medicine in general. And some of that is historical, meaning people who went into medicine expecting one thing and it either was something else or turned into something else. One of the classic things is in the past, medicine doctors, made a ton of money.
Yeah.
They were, and their hours were great. And
yeah.
they got the best table at the restaurants and they were so, they were the high society. And that is not how it is now.
That's gone.
And so a lot of people sort of went into medicine in one, with one culture and it sort of turned to something else that got very bitter. And also, things in general around that time were changing about requirements for documenting and malpractice. And, at the same time with OBGYN, you're up at night and the hours are so hard and it can definitely be that. And sometimes it's also just, you don't see all the happy times. When you're a medical student, you're in the hospital, you're basically just seeing people who are running around the labor floor, people at night at 3 a.m. and you're like, wow, these people don't want to be here. But you don't see them like at 2 p.m. when they're with the patient and really enjoying their job and say, oh, this is great. I'm a little grumpy at night. That happens sometimes. But it is one of the things that a lot of medical students talk about and sometimes drives people away from the field, unfortunately. Mm-hmm. I think that a lot of that is different now in what I see. I think that people maybe have their eyes open a little bit more when they're in medical school and residency. And the people for whom OB or GYN would be very difficult for them or very upsetting, just don't go into it. And so I think the general attitude is, it seems a little more happy-go-lucky now amongst our field, which is nice.
Yeah, I agree. I even see this in medical students now. They're so more focused. I think they really have a good sense of what the field is. And they really come in understanding, well, these are the things I'm interested in. This is what I like. I know this is tough, but this is what my passion is, which I think is really, really good.
Right. And it's so hard to get into medical school now. Yeah. And people that age who are trying to make it big, they're not going to medicine. They're going into tech. They're going into business school. They're doing, something venture capital and great, God bless them. Good for them. And the people who go to medical school now, it's crazy. I look at these, these applications, these CVs, and I was like, I'll never get into medical school if I applied now. They have like Nobel Prizes. It's like unbelievable.
I see that every day, even for the people who are going into fellowship who reach out to me. I'm like, I would never get into fellowship now. You guys were just amazing, which is good. I think it's a move in the right direction.
Yeah. And the students who go into it are so unbelievable and so qualified and so smart, but they realize they're choosing medicine for reasons that are not the same maybe than that we chose or people generation before us chose or whoever it was. And so I think there's less of that. And we're also, I think, doing a hopefully better job steering people into the right career paths as mentors, which you are now one yourself.
I'm trying.
Wow. So that's how you got into medicine. And as you said, you're interested in OB. And when your resident, by Jolynthia was an awesome resident. She was,
Oh,
amazing doctor, amazing person. Everyone enjoyed and enjoys working with her, except Melka. She said she can't stand you.
well, I'm scared of Melka. We have this running joke about who's scarier. I think she is, but she totally thinks I am. So, whatever.
Yeah, I don't think either of you are too scary. You're both pretty chill. So you said that you were drawn towards the adolescent population, and what is it about that population that drew you to them? Because everyone else on earth wants to avoid them entirely.
They're going to get away.
Yeah, I have 4 of them living in my house, and and I love them dearly. But if they weren't my children, I'd probably just run away from them.
It's like my mom said, like, I love you, but I don't like you. That summed up my teens. If she hears this, she'll laugh at that. Because
she'll hear this. Yeah, we're gonna send her a link.
In medical school, actually, I really realized I love this population because they reminded me of myself and my friends when I was an adolescent and desperately needed guidance and not having the information. A lot of my friends, a lot of my family members and myself, there were some decisions that we made that really impacted your health that was not ideal. And if you had someone that took the time to explain it to you in the way that you understood, then I think things would be a different way. So literally having a teenager when I was in med school come in very scared about something so minor, but they're really, really nervous. And being able to say, listen, this is what it is, you're fine, this is absolutely nothing. And seeing that their disposition change, seeing that they're happy, hearing their plans for the future, and being able to just make that impact at that one visit, that really got me into the field and say, hey, this is something that actually I love to do. So after seeing maybe 10 to 15 people in the clinic, I was not tired. I was happy. I was excited. Very different than how I felt after every other clinic.
Right.
So that was really like, this is the population that I think I like the most. But at that point, I had no idea this field even existed.
Right.
So it still was not on my list of things to do. It was just like, I really enjoyed this population.
Right. So just for some background, what Jolynthia is referring to is after OBGYN, there's several options for, fellowship, what we call subspecialty. So for example, I do maternal fetal medicine, high risk pregnancy. Jolynthia mentioned before something called minimally invasive, which is a type of, learning how to operate with, laparoscopy and robotics and whatnot. And then also, urogynecology you mentioned, and oncology, cancer. And there is a subspecialty of pediatric and adolescent gynecology, but there are so few people who do it. I mean, when we were training, there was one person at Mount Sinai, Dr. Albert Olchek, a blessed memory, who was an unbelievable doctor. And he was really the only person around who did this kind of work, who would see, either young girls or teenagers who had different problems. And he was trained better than anybody. I mean, he knew everything, but he was the only person to see. And there really weren't a lot of other people you could look to say, oh, he does this, she does this, what a great field. And so there weren't opportunities for as much mentorship or understanding about that subspecialty. And that's mostly because it's not all that common, right? Most girls, when they're, young or teenagers, don't need to see a gynecologist. And so they're not all over the place in a sense. And so how did you end up finding training for this?
Good question. It was difficult. It really goes back to second year of residency when I was kind of like, where do I want to do with my life? This is the population I like. And I literally spoke to one of my mentors who's no longer here. And they were like, well, let's just Google to see like what an OBGYN who's interested in the younger population, what can they do? And I stumbled across the North American Society for Pediatric and Adolescent Gynecology's website. And I believe there were 4 training programs in the entire United States at that point, with 1 or 2 in Canada. So at that point, there wasn't a lot of information. You kind of read, this is what they take care of. This is what this subspecialty of gynecologists do. But I really had no idea. So what I did was I looked into the fact that they had an annual clinical research meeting, and I went. So I believe 30-year residency, I went to the clinical meeting, and it was 2 days, and I fell in love. It literally spanned from everything from STD testing to some very complex cases that I had no idea even existed. And it really married adolescent medicine, which is a pediatric subspecialty, with gynecology, with urology, with gen surgery, with everything for this younger population. And I knew at that point, this is exactly what I wanted to do.
Right. And so just for context, when Jolynthia says there was 4 programs in the U.S., for maternal fetal medicine, there are, on any given year, 100 to 200 fellows, people who are training in that subspecialty. So you're talking about, that versus 4, and so it's just the numbers, and also the operations that are generally for congenital abnormalities, meaning girls who are born with certain abnormalities of the genital tract that have to be repaired, corrected, or, either as babies or as children or as teenagers. And so these operations are sometimes very complex and involve, the bladder, the rectum, and there's other specialties that get involved. And so, as you said, it is very complicated, and you don't get to see a lot of that in training.
Right. Absolutely. There are a lot of young women now, older women and young girls who continue to have delay in diagnoses, not getting the right treatment, just because in order to be trained in this, it is so unique and you have so few sites. So it was really, really important. One thing that I really learned in training is that it's important to not only see it, but in order to also know where are the major centers that you can refer patients to and then manage them, right?
Right.
So it's a very unique specialty that I love to get into the nitty-gritty for, but it really let me realize, I've always been interested in disparities because that's what I really cared about when I was 14, right? Making sure that we don't impact young women in this way. And although it's not obstetrics, it's in a completely different realm that I didn't even think about or appreciate. The other aspect that I really loved when I went to that clinical meeting was the pediatric population, who I had no idea would be interested in seeing. But think about seeing a 3-year-old or 4-year-old for a gynecologic problem. Could you imagine how the child is nervous and upset, and the parents who have no idea what's going on? And to be able to really educate, to be able to help and see that smile and impact that family moving forward, I'm like, sign me up. This is exactly what I want to do.
Right. And just to focus in on that, if a 4-year-old has a gynecologic problem, right, the pediatricians aren't trained to deal with it. I mean, if it's something very, very common, basic, all right, fine, that they see all the time, okay, but they're not trained to deal with it. And gynecologists aren't trained to deal with it because they're not going to have the same problems that adult women are going to have, obviously. And so you're sort of left with, well, who's going to take care of my daughter?
Exactly.
Right. Who can do that? It just, pediatrician's like, I don't know. And the gynecologist is like, I don't know. And so that's where you come in. I mean, you do a lot of other things, but that's where really like you come in with like a cape on and a big S on your chest. And like, I am the one who can take care of your daughter because I know what I'm doing.
Yeah.
And I've seen this and I know what to do. And that's like really where your specialty, I think people don't even realize that this exists. People don't, because again, most people, their daughters don't have gynecologic problems, but for those who do and who have found you or someone like you, they'll say there's like no one else on earth who could take care of their child.
Yeah.
And that's incredible. Where did you ultimately train, just so everyone knows?
So back to the marvelous Dr. Fox and how he's amazing. Had it not been for him, I would not have been here because I almost did not do fellowship. So as you mentioned, the additional training needed. At the end of third-year residency, I wanted to just get life started. I'm like, I want to do this. Maybe I'll make it my little niche and I'll do it that way. And you really said, literally, Trotman, what are you doing with your life? We were on the labor floor one day. I said, I think I'm going to just, do general OBGYN, nothing against general OBGYN, and I'll make adolescents my niche. And you said, well, why not do the fellowship? And I didn't have a good reason. And you said, well, you can always go back. If you did fellowship and you didn't like it, you can always be a generalist, but it's going to be hard to do the other way around. And I literally took your advice and I applied. So thank you for that. At that point, I mentioned there were, I believe, 4 programs that were actively taking fellows and maybe 2 others that weren't in that cycle. That's how little people were being trained. And I ended up going to DC. So I went to MedStar Washington Hospital Center that has an affiliation with Georgetown. And the Children's Hospital is Children's National Medical Center. So I trained in DC, Children's National Medical Center, under Dr. Gomez Lobo, who also was at Mount Sinai at some point, and she is phenomenal. And really, fellowship was literally learning medicine all over again, because there is very little aspects of residency that prepares us for pediatric and adolescent gynecology. I had to unlearn a lot of things, and I had to approach patients from day one in a very different way, literally from day one. So it was definitely necessary. And I think had I did the other way, I would have made a lot of mistakes and stumbling blocks and probably never be able to really understand how we generally approach patients, because you do lose patients when you walk in the door. If you're not prepared for that first initial experience or exposure, especially with the younger patients, you're not going to be able to impact them in any way.
Right. And how long is the training?
So the training varies. When I started, you had programs that were 1 year to 2 years. Now, for the most part, most training programs are 2 years across the board. I think with the exceptions of some programs in Canada, we're really moving towards having it organized because we're hoping to become certified one day. ABOG, which we'll explain what that is.
Because no one understands.
Because no one knows what ABOG is.
Yeah.
So our governing body has actually moved towards some sort of focused practice exam for people who have an expertise in pediatric and adolescent gynecology, which I call PAG. So now we have about 11 or 13 training programs since I trained.
It's a lot.
The hope is that every children's hospital has a PAG provider available, and every OBGYN program has a PAG provider available.
Right. I mean, ABOG, the American Board of OBGYN, basically oversees, our training and credentialing and things of that sort. And there are some fellowships or subspecialty training which are officially under their auspices, meaning when you finish, you take a written exam, then you go to Dallas and take an oral examination. And assuming you pass both of them, you get, a certificate that says you are board certified in this subspecialty. Like, so maternal fetal medicine has that. So I got board certified in OBGYN. And after I finished my fellowship training, I had to get board certified from the same board, but board certified in maternal fetal medicine. And that's true with a lot of subspecialties. Some of them, particularly ones that are either very small or sometimes newer, they exist and there are training programs, but they're not yet under the auspices of ABOG. So there is no formal credentialing board certification. The upside is you can train without doing all that stuff. The downside is if you're a patient, it's hard to know sometimes what kind of training does this person have in that subspecialties. It's someone, like you said, you might do on your own is, I'll just do OBGYN and, specialize in seeing adolescents, and I'm sure you would have been great at it, but as you said, you wouldn't have had that formal training and maybe not all the nuances or maybe not the volume. And so people, when they would come to you, they wouldn't really know the difference. But now it's sort of, formal. I did this training and, hopefully if it does get accepted to be under that, ABOG, you can say, okay, I'm board certified. And then you'd probably be one of the people like giving the exam as opposed to taking the exam. And when you mentioned Dr. Gomez Lobo, so she was, when I was a resident, we actually had in 4 years, I think 4 residency directors. I guess we were not a great class. So she was my residency director when I was a second year resident. And she was awesome. And she's one of the people who helped. It's so funny that she was like your person for doing PAG. And I look at her the same way for me doing MFM, that she really pushed me to do it. And she was an amazing teacher and mentor. And she would, surgeon and just a really great doctor. And so I'm happy that you went there. And listen, I still agree with the advice I gave you. Then if it's something you want to do, then you should get as much training in it as possible because A, you'll be excellent at it. B, you'll feel more comfortable doing it. And C, you'll really get to focus your career on what you want to do. If you sort of, I'll do a little this, a little that, maybe it'll work out, maybe it won't, but you may as well. And, I'm always in favor of people making very little money for a longer amount of time. It's just great to train. Yeah. And so now you finish your training and you come back. What do you do on a typical day or week? So, what kind of things you do? Because people don't really understand maybe what your schedule would be like.
Right. So that is variable. So what I do now, being at Mount Sinai, is I have a really good range of a more basic PAG, and I'll discuss what that means, to some complex. So I'm really building up that complex aspect of my care. So for the most part, my week involves really great hours for doctors. So, 9 to 5 office hours. And, in that time, I'm seeing bread and butter. So some reproductive health counseling, some 14 or 13-year-olds, to a lot of problem visits. And I like to break up my problem visits into prepubertal or young girls who have not yet gone through puberty or have had their first period, and postpubertal. So I go from anywhere from a newborn to about age 24, 25, which is when adolescence really, really ends. So people don't think that 23-year-olds are adolescents, but they really are. All of their brain synapses hasn't quite synapsed fully yet.
Yes, I'm aware.
You're aware. So
unfortunately, I'm 45 and my brain synapses have not. They're not there yet either. But I'm working on it. Hopefully soon.
So A benefit, and I'll go to what I do. A benefit is I get to spend more time with patients. So a typical new patient visit for me is about 40 minutes, which I think is really a privilege, and especially with how medicine is today. And it really bodes to Mount Sinai and the fact that they've really focused on making sure patients get optimal care. So for the prepubertal girls, I really spend time really talking to their moms and gaining the interest and the trust of the patients. And they mainly come in for vulvovaginal concerns most often. So lichen sclerosis or disorders of the skin, vulvovaginal itching. Sometimes you have early puberty in the younger age groups, some pelvic pain. And every now and then we do get the more complex young patients. These are the patients that are born with their uterus may not be fully developed. They may be born with or without their complete vagina. I do share patients with pediatric surgery and pediatric urology. And these are the patients who their anatomy didn't quite fully form as it should, and there are connections where there should not be or no opening. So I do, share those patients with them. For the most part, those families are just being counseled about what to expect as your child ages, what to expect for childbearing, for, the health of the vagina, for the uterus, for the ovaries, and those things. And very rarely we need to do surgery on patients that are in that age group. So for the most part, that age group is going to be mainly counseling and some medical management issues.
Because they'll need surgery later? They won't need surgery at all?
Yeah. So for some disorders, they need surgery very early. And some of them would have had surgery maybe within the first few days of life before they even met me. And then later, GYN always comes in to say, okay, if your vagina is connected to the bladder, what does that mean? If there was one tube for everything, what does that mean? Sometimes we do have to, as a GYN, do surgery early on, mainly for diagnosing and for identifying what the anatomy may look like. Sometimes, not to be too complicated, but to remove some of the structures. So if the uterus is attached somewhere in the pelvis that it should not be, sometimes the answer is actually removing that piece of structure before they go to puberty and need a bigger surgery, right? Or sometimes just like connections. And there are some large centers that actually do some of those more complex reconstructive surgeries, but there's always a role for the gynecologist early to counsel the families on, what does this mean for my child as she grows? Is this important? Is this going to impact her health? Issues surrounding fertility does become an issue even for a 3-month-old because the parents have already named their grandchildren, right? So that really is important. And we have found that families who get counseled early on for these very complex cases about their reproductive outcomes are happier and are more knowledgeable.
Yeah, and it makes so much sense. I mean, listen, I'm a parent, and when something's going on with your kid, that's it. That's all that matters in the world. It's all that matters in life. And, their kid has diabetes, which is a very difficult diagnosis for parents and kids. But we know what it means. Like you can get it, you can understand, you know how to treat it, you know what to expect. And so, okay, like you could put it in a box and sort of figure it out. But something like this, for most people, it's a complete mystery. They never even thought that this was possible. They never understood that this was an option or what needs to be done. You can't really Google it. There's just it's just such a complicated thing. And each individual situation is going to be unique, right? It's not just like, well, there's the 3 possible things that could happen. There's 3 million things that could happen. And so to be able to go to someone and say, okay, I understand what's going on. Here's what it means for childhood. Here's what it means for adolescence. You may or may not need X surgery. This is what's going to mean for your life, for fertility, for health and whatnot. It changes someone's entire childhood, themselves, and also their parents.
It does.
Because in that age group, it's really more the parents than the child in that sense.
The parents, yeah. And the parents get to advocate for their child. And as a child is growing, I like to say, you want to normalize this. Like, you don't want to make the child feel they're an outcast and kids are so resilient. And if you tell a 3-year-old, 4-year-old, your body is different in this way and you're unique, they're going to grow up understanding that. And when they're 14, 15, when the real peer pressure starts, they're going to be more resilient as opposed to, what was this? I've been hiding. There's something wrong with my body. That just adds stress to an already stressful time.
Right. Do you find that a lot of parents want to keep this a secret from their children?
That's a good question, and it depends on where I am in the United States.
Okay.
So I do find that some parents who, I think they want to overprotect their children. I guess it's a better word, but I do have a minority, maybe about 10% of parents actually do want to keep it from their children and actually come in without the child. And then it's a lot of counseling to the parents surrounding why it's important for the child to know and make some of these decisions.
Right.
So there is an entire body that have moved towards doing any surgeries in younger children if it's not needed for life, to wait till the child can make the decision earlier on.
To help
and
them be
really,
involved.
Yeah, and really give the child back the autonomy. So I
Right.
do find there are some parents, but most often we're able to really counsel the parents to like make them feel comfortable enough to bring the child in.
Right.
So it's rare that I've had a parent that has refused. I have had one or two that's absolutely refused and I've never seen them again.
Right.
But for the most part, after you counsel and you kind of get them hooked up with support groups and show them, you know, the data, have them meet other parents maybe over the phone, most families are open to introducing that idea to their kids.
Right. And since it's not, usually emergent, you have
Yeah.
a long time to sort of talk, and people, go through their process. They
Mhm.
first, sort of understand what it is, then maybe accept and, sort of come to grips with it, and then
Right.
are ready to move forward. Maybe
Right.
not on the first visit, but eventually. Okay, so that's in the
That's in the pre-pubertal group.
and then your adolescents.
And then
You're,
right.
11 to 45 now. 11 to 24.
Right?
Okay, yeah.
So, and that you can have a lot of the same issues as you do in the pre-pubertal, but here comes a lot of your menstrual disorders. So issues surrounding periods, pelvic pain, ovarian masses, pelvic masses, really gender diverse care as well. That's another thing that we do very often for both the post and the prepubertal as well. Polycystic ovarian syndrome, which also goes under menstrual disorders most times, but not always. Fertility preservation things. This is coming up a lot more for us as well, as there is a lot of survival from childhood cancers. So we do have a lot of patients who have been diagnosed who are coming to discuss fertility preservation either before or after cancer treatment. And this can also be true for the prepubertal group as well.
Right. So you mean like someone like a teenage girl who's about to undergo chemotherapy or radiation, and they're
Right.
worried that it'll induce sterility.
Correct.
And so there's options potentially to harvest eggs
Yeah.
and, freeze them so
Right.
that later in life she can, because again, her uterus is still there.
Uterus is still there.
But
Mhm.
if her ovaries are not working and she's, sort of menopausal as
Right.
a young woman, you could take hormones to fix that, but it won't make you fertile again.
Correct.
So that can help.
Yeah.
Wow, that's amazing. I didn't even think about that.
Yeah, we do that. So we are obviously we're not reproductive endocrinology, but we do a lot of the counseling, and there actually is ovarian tissue cryopreservation or removing either the entire or part of the ovary that we actually can do for ourselves. And if you're in a lot of children's hospitals, the pediatric gynecologists are actually doing that procedure and working with their reproductive endocrinology colleagues in order to harvest eggs and those
Right.
things. So we do a lot. There are complete programs that are really focused on fertility preservation, and not only for cancer survivors, but for blood disorders, for patients who are transgender. There's a lot of movement in that area as well.
Wow. And how do people come to you? Are they referred from their pediatrician, from a gynecologist? Do they find you on Google, from friends? Like, how do people even know to come to you?
All of the above. So I've literally had a mom who said that she had a 3-year-old with vaginal bleeding and she knew nowhere else to go. And she Googled, she found me, and she showed up at my office. So that's one way. Pediatricians. So we do a lot of outreach to pediatricians, let them know that our services are here.
Right. They must love you.
They absolutely love me. And I love them.
Yeah, they must. I mean, I just can't imagine
love
any
them.
pediatrician who would not want to say, "Oh my God,
Yeah.
please see
Listen.
Jolynthia." Like,
Yeah.
thank God you exist.
They send me a lot of complex contraception. So they could obviously prescribe birth control pills, but
Right.
if there's bleeding, if there's problems, if she has some medical problem, then I take those. A lot of pelvic pain, and they ask a lot of questions. They send me a lot of patients, and
Right. The other way to get patients is they text me and I text you.
Yeah.
Who am I supposed to
Easier,
see?
and I see as soon as possible. From OBGYN, I do get some patients from my OBGYN colleagues. And then from the pediatric urologists and the pediatric surgeons, they actually send me quite a bit of patients as well, which is excellent because PAD cannot work by ourselves. We just by virtue of how we are and the complex level of patients we see, we have to work together. So the other group that's super complex that I really love to take care of is the group that has ovarian failure. So primary ovarian insufficiency at a young age. So we do a lot of hormone replacement therapy. So we work a lot with endocrinology in that aspect. Bleeding disorders. So we work with hematology. So we see these young ladies who are more complex than general because they can see a general OBGYN. You know, there's nothing really specific about just needing birth control or contraception. It's when you have this higher level of care and there are things that can be done that could be potentially harmful, that it really helps to have someone with our expertise.
Wow. And are all the people who do PAG, are they all first OBGYNs who do training, or any of them pediatricians who then do surgical training, or any other way to get sort of an entry into this field? I imagine there's people who do adolescent medicine who aren't GYNs, but the people you work with, are any of them trained differently?
Yeah, so no, for PAG, they're all under OBGYN, but we do a lot of cross care with adolescent medicine. So there are a lot of adolescent medicine specialists who do LARCs, so that's long-acting reversible contraception, so IUDs and Paraguards, and Nexplanons. They do a lot of complex GYN as well, minus the surgical aspects, and a lot of them are really, really good. So I tend to work with that field a lot. There are some PAG providers that are actually housed under adolescent medicine. So if you go to different programs, you may find a GYN listed under adolescent medicine, which works really well. I actually spend 2 days a week at the adolescent health center, which is awesome. So that's where patients see me a lot. There are some of us who are housed under pediatric surgery. So that's another way that we can be housed. So although that's our specialty, we actually work very closely with those groups.
Right. And a lot of that is, as you said, relationships. The more time you practice and the more, sort of interaction you have with like the pediatric urologists, you said pediatric surgeons, they're just going to know you're their go-to person and you do a lot of cases together. But, I assume that most of the listeners of this podcast would be probably mothers or fathers of your patients. I mean, I assume, we may have some teenagers or young adults who listen, but how would someone even know that they needed to come to you? Meaning, who should be asking to see a pediatric or adolescent gynecologist? They just, because they see their pediatrician or whatever it is, and maybe not all pediatricians refer to you or know about you. What could a parent do to maybe advocate to see you, and what circumstance would that happen?
And that ranges from I, as a parent, have no idea what to expect, which is surprising. I find that a lot. I'm like, weren't you a 13 or 14-year-old at some point? But it's a different time. So if there is any problems with the period, and I think that is like the first step, right? So most of the young ladies come to me or are having challenges that way. And that's how I get a lot of the first set of patients. So this problem with the period, I don't have that at all, or she's having it too much. That's really the first step to say, hey, I need you to see someone who has a specialty in that, in gynecology for teens, because a lot of times people are masking it by just throwing on birth control pills. And that could completely change or delay a diagnosis for many, many years. And we're able to kind of really delve into what is the cause first before we start, what the treatment is. So that would be one of the first things. A lot of pelvic pain. So we have a lot of young women who are suffering. And a lot of times moms say, oh, it's okay that your period hurts because that's how it was for me. And they're suffering, they're delaying diagnosis of endometriosis. There's a delay in a diagnosis of uterine problems, that the blood isn't completely, being expelled. So those are the first two things that I would say for the general public. These are the things that would most likely come to me. Also, vulvovaginal stuff, a lot of burning, itching, irritation that's just not going away. These are the things that really affect quality of life that we can take care of pretty much usually relatively quickly.
Right. And, when friends or colleagues, talk to me or ask me questions, I mean, generally for almost everybody, they're going to speak to their pediatrician first. That's pretty typical. And when people call me and ask me and say, hey, my daughter has this, and we saw a pediatrician, and then, she sent her to get an ultrasound, and then she sent her to an endocrinologist, and then to a radiologist. And I say, like, do you have someone who's like young? Yes. Is the problem gynecologic in any way whatsoever? Yes. See a pediatric gynecologist. Like, they exist. And if they're not available, like if you're in a town where it doesn't have one, okay, fine, then maybe it's not possible. But like we have you. And so like I said, just to see Jolynthia. Yeah. Like, it's the easiest thing in the world, because this is her expertise, and because she's an expert in young people and in gynecology. And when there's a confluence of those two, you really want to be seeing a specialist. And I want to switch gears for 1 second. When you're seeing these, girls, young women, young ladies, as you said, how do you address the idea that they're so uncomfortable to see you? I mean, they don't want to see you. I mean, they don't want to see anybody. They don't want to go to doctors, and then you're like, you're going to the gynecologist.
Yeah.
And, as a 13-year-old, they're terrified, they're annoyed, they're miserable, and how do you make them feel comfortable, number one, just to open up and talk to you, which is difficult with all teens, obviously, and children. And number two, you may have to examine them. And that's also very difficult for anybody, but certainly for that age group. How do you do that?
Yeah. So I think some of that can't be taught. I think some of that really comes back to personality as well. But the first thing is goes back to what I said earlier. When you walk into that door, you can really make or break your relationship. So the first thing is you must build a relationship with the patient. If your patient is 3, or if your patient is 13, or your patient is 23, if the care provider, the parent, the guardian is there, you have to go to the patient first. The other thing that we do is we tend to dress down. So I tend to not dress very professional, never wear a white coat in the office unless I'm in the OR, because that's the first boundary. So you really want to make yourself into almost on that patient's level so the patient trusts you.
Right.
So
You're a normal person.
You're a normal person.
Yeah.
So, which helps me for my wardrobe. I don't have to get super dressed every day. So you really want to make eye contact. So one of the best stories I had, I think she was like 4 or 5 years old. She hated doctors. Her mom said she hates every doctor. She hated me the first 2 seconds of our visit. She refused to do anything. By the end of the visit with an examination, she was telling her mom, I really like that doctor. I really like that doctor. So how do we get there from the patient really being afraid, which they've probably seen a couple of doctors before they've seen me, and you're delving into a private place that their mom or their caregiver has said no one should be looking for pretty much since they know what's going on. So how do you get there? So I tend to do a lot of younger kids, a lot of talking, how's school, how's everything, playing, giving stickers depending on their age, really building up that trust. And I gauge what's important for the patient. So there are some patients that I know I'm not going to be able to examine them today, and that's okay. There is usually very little reason for me to require on this day, I must do an exam on this patient. And if I think that's going to bring additional stress and that's going to bring additional strife, I let them know early. Today, we're just talking. Today, we're not doing anything else. We're just going to talk. You're going to let me know, and then we'll go further if we need to. Usually, I can get past 90% of patients with doing an exam in that way. So I'm building trust. We're playing. We're talking. For teenagers, I'm really more interested in what's happening in school, what's happening in life. I always, and this is a strife sometimes between the parents and I always do a confidential part for any patient who's about 12 and older. Sometimes a little bit younger, depending on what the presenting complaint really is. And at the time of that confidential, we really spend a lot of time relationship building. So I think a lot of families think they step out of the room, we're like, so are you having sex? And it's usually that really is the last thing I ask, because I want them to feel comfortable with me. I'm an adult. So why are they going to want to tell this stranger who's an adult what they're really doing? Now, maybe 10 minutes down the line, after we've built up that kind of rapport and they know they can trust me, then we may decide, okay, let's talk about some sexual things. Who are you attracted to? Are you doing anything? Does anyone make you feel uncomfortable? So we spend a lot of time relationship building, and that then allows me to do an exam. And the exam is always driven by the patient. So there are some patients that leave and I never do an exam on them until maybe the second or the third visit even. And that's okay. That's usually okay.
Right. What do the patients call you?
Oh, it depends. Dr. T. Some patients call me Jill. I do have some patients call me by my first name, which is completely fine. And some call me Dr. Trotman. But,
Right. So whatever they're comfortable with.
Whatever they're comfortable with. And I ask them what are they comfortable with being called. And, so that's what it, honestly speaking, if the patients call me Jill, I would be completely okay with it if that is what builds the relationship between us. Because it's always going to be a respect level there.
Right. Right. I mean, they know who they're saying.
They know what they're saying. Right. Yeah. The other things I do for my younger is distraction. So these phones, the iPads, the whatever gets them through that exam, I tend to let parents know it's okay in that moment. So if they want to look at Peppa Pig or whatever while I'm doing their dental exam, that's fine. And I ask permission of the younger kids too before I do any exam.
Right. Well, it's also a lesson that they.
It's a lesson.
Yeah, because they need, because they're, as you said, they're told off limits. But this idea that even a doctor should be asking you to make sure it's okay.
Right. And I tell them, I'm like, I always do a test. So who can tell, what do you call your private part? So we get the name, then who's allowed to look? So I figure out, and they're telling me, I'm asking them, not the parents.
Right.
What if someone in school was to ask, what would you do? And then I ask for their permission and I say, it's because mom is here, dad is here, or grandma is here, and there's a problem. So is it okay if I take a look? And if they say no, then the answer is no. Sometimes mom has to take a picture.
Right.
Yeah. And that's it.
And you must obviously be screening for and unfortunately picking up cases of abuse.
Yes.
I assume.
Yeah, which is fortunately very rare, but I have picked up a few cases of that. And it's always, that honestly is the hardest part of my job.
Right. I mean, that's just awful.
It's terrible. Yeah.
It's probably rare because people won't take them to the doctor for it. It's if someone else takes them to the doctor and you realize, what's going on. that's, that's devastating, obviously. And then when you have to examine them, like you said, if they're older, right? So if they're children, if they're, let's say, 5 years old, 6 years old, as you said, and the parents are there, what do you do with the teenagers? Is it the parents are out of the room and you have someone else in the room with you, or how does that work?
I figure out what the teen wants at the time of our confidential.
Mm-hmm.
So I give the support person no say. Obviously, if the patient has developmental delay, that's a different story. But if
Right.
not, I just ask them all to step out. And in that confidential, at some point, I say, okay, we're going to do an exam and this is what we're going to do. Because sometimes I don't even have to look. But if we do you want XYZ in the room or do you not want them in the room? And if sometimes they want them there and then I invite them back. Sometimes they want them in the room but behind the curtain and that's okay. And then I ask about the chaperone. So do you want the chaperone in the room or do you want the chaperone standing behind the curtain? So I give them that leeway. And some young ladies say they want no one else in the room but just me, and they understand that that's okay, and we go with it. So I basically let them decide who's going to be there in the room with
Right.
with
It
me.
sort of gives them a sense of power over what's happening.
They should have power.
Yeah.
They should be able to advocate for themselves. They should be able to tell me how they really feel and not do what I say. So I really give them a lot of the power in that way.
Right. And how do you delve with sort of the whole mental health aspect? Because you must pick up a lot of, anyone who sees children and teenagers is going to be working with mental health, but obviously in this particular arena, it's going to maybe be more prevalent. Is that something that you focus on, or you have colleagues who you work with, and how do you navigate that?
It's something that's very prevalent. And I find a lot of our young ones have anxiety today. And not only the teenagers, but even some of the younger patients as well. So I do my own, like some mom told me I'm like a counselor. So I do my own screening with and without the families there. And I kind of gauge as to if this is something that's just basic anxiety, basic depression that, we can kind of talk through, or if it's something more severe. I work with a lot of really good social workers at the Adolescent Health Center. So if I have anyone that screens a little bit higher than I think I'm comfortable, or they don't have a therapist or someone they can speak to, I always refer them to the social workers there.
Right. And this is something that the parents would know about.
This is something that the parents would know about. We
Yeah.
work in the confidential part. If there's anything that's mental health involved and there's any concern of harmful behaviors or even being depressed or really anxious, I do ask for permission for the anxiety and the depression, but any screening for self-harm or
Right.
harm to someone else, that is something that we immediately get the guardians involved with.
The last thing I wanted to talk about is that very complicated balance. And we were speaking about this before we started recording, this idea of, as children get older, you want to give them more and more autonomy over their own health, their own decisions, and let them make, those choices for themselves. But on this same hand, they're minors and they have guardians and they have parents. And for most things, whatever, it doesn't really make a big difference either way. But in some situations, there really is maybe a conflict there. And how do you navigate this idea of giving the teenagers, let's say, or even, older children, giving them the idea that they do have autonomy, they do have power, they do have confidentiality and all these things, and then the parents? And I assume some parents disagree where you draw the line. And how do you navigate that in terms of A, what you do, and B, when it is a conflict with what the parents want you to do?
Yeah. The conflict part is hard.
Yeah.
So this was actually my key research and fellowship.
Oh.
Issues surrounding confidentiality and how do you navigate that? Because we've had some patients who have said, I'd rather die than let my parents know XYZ.
Right.
So, and that's not unique, to be honest. So
Right.
What I tend to do goes back to relationship building in the beginning. So I see everyone at the same time. So I have 3 visits in one pretty much. Right. So walk into the room, I see the parents or the guardians and the child at the same time. And before I do the confidential, I say, all right, we're going to spend a little time a little bit later. I just want to reassure you that anything that comes up as it relates to the medical problem today, you will be a part of the decision making. And I give a lot of input and a lot of information to the families before I ask them to leave the room, because I may be, and usually I am the first physician who's actually successfully had them step out of the room. And that's hard for parents, especially if you have your 13 or 14-year-old and they're in pain or there's something going on and you want to make sure you're part of that medical decision making. So my research actually found that was what parents were most concerned about. They weren't really so concerned about the sex and those part of it because they thought they know exactly what their kids are doing. They were really really afraid that they're not going to be part of the medical decision making. And the kids actually were afraid sometimes when their parents left the room as well. So I do spend time saying, okay, we're just going to talk about some things, make sure you're safe and healthy, and your mom or your dad, we're all going to make the decision together. Once I say that, I very rarely have someone leave the room. Or if I do, they're standing very close to the door,
Right.
but they usually do leave.
Because I mean, all people who take care of children, pediatricians have this.
Yeah.
And there's all, they talk about how do we navigate that and at what age and for what questions. Okay, but that's for, pediatrics.
Right.
When they're coming to see you, it's like that idea on megadose steroids, because it could really explode potentially. These are very high stress situations.
Absolutely.
And so I listen, you're obviously a great communicator and you're doing an amazing job. But what if the parents disagree and they say, listen, I need to know, or I can't have this. Is it just sort of, it is what it is. This is how I do things. And
then I say it's protected by New York state law.
In which way?
So there is all
right.
Teenagers.
Is it really protected? Or is it sort of like what I used to say to my campers in Wisconsin when they said, I want to sleep in my sleeping bag, but no, you can't. It's Wisconsin state law. It's against the rule. Like, really? Yeah.
So they actually do have, it is protected. The reproductive rights for teenagers are protected. They are considered emancipated minors as it pertains specifically to reproductive things. Now, granted, I may be talking about school,
right?
But I do need to get to that because we would be surprised the amount of young ladies who come to see me because they have pelvic pain and my period hurts. And the minute someone leaves the room, it's like, I really need birth control because of XYZ. So you would never get that. But then once, and I do want to reassure parents who's listening, I'm not in the habit of encouraging your child to not be honest. So at the confidential, if something comes up that's not critical, but I think it would behoove them to let their parents, who are the number one advocates, know, we work around that. I'm like, okay, so how can we tell dad or how can we tell mom? Do you think it's safe? Like, what do you think is her biggest concern? And I try to get them to be honest and open. And sometimes we're able to successfully navigate that together. And sometimes we're not. And that's okay too, because I'm okay being the person that they can come to say, this is happening. How can you help me in this situation? That's okay.
Right. And they're in the situation to begin with.
To begin with.
Right. You're only making it better, not worse.
Only making it better.
Right.
I actually have parents who I see before I see the kid. It's not unusual that the parents ask to speak to me in private before.
Right.
For, I just want to let you know. And I'm like, okay, sounds good to me. Or, after the visit, I need to call you after so we can really dig into the details. And I have had some parents who have demanded to know, what are the results, or I need that virginity check or some of these things. And if I have to drop the line and say, I will not do this, this is morally wrong, or this is protected by the law, and I'm not going to divulge any results to you. And that's just the way it is. And I have had to do that.
But that must be the exception.
This is really the exception. Most parents, to be honest, are really reasonable and rational people.
Right.
And for the few that have a problem, sometimes they don't come back. And, I sometimes I'm just concerned, and I always give the child my contact information or let them know their websites that they can go to. So even if they don't come to me, there are some websites that I do give out that they can get good information from.
But the majority is, like you said, it does work because you're on the same page as the kid, as the parents, and everyone's working together towards these things. It's just an interesting concept. And, we talk a lot about what if, but like most things, most of the time, none of those things ever come up. It's just everyone's, really, really happy that you're there.
Yeah. It's usually a love story. I know I love my families. They love me. We really have a good relationship. And that's really important because a lot of times, this is a different generation, and there's so many things that are available now that was not available then. So much more mental health issues. I think that's not really around, but really coming to light. So I think moms are very thankful that they have someone that they can navigate that with. And sometimes they call me because they're like, she doesn't believe me. Can you spend time talking to her? And I'm like, absolutely.
Right. I mean, I know that there's just in the past, year or so, because I see basically pregnant women, so I don't have a lot of opportunity to refer, adolescent gynecology to anybody. But, I have friends and I have patients, and I've got, 3 calls in the past year from people I'm close with who said, my daughter is A, B, and C, whatever it is. And what do you think? This is what the doctor said. And I said, go see Jolynthia. I said, please, here's her number, make an appointment, see her, and all three of them, and one was an office visit, one was 2 office visits, one was an operation. I mean, there was all these things, and each one of them sent back say, thank God for her, and thank God you sent us to her, because it's night and day.
Yeah.
And so I'm obviously still your biggest fan. I was when you were a young tadpole starting residency, and now that you're the big fancy professor and PAG, I remain such. I'm so happy you came on. Thank you for coming. Thank you for talking about what you do. Thank you for helping all these families and these young ladies and their parents and everybody involved. The world is a better place with you and your colleagues in it. That is for sure. As a parent, I can tell you that as well. Thank God there are people who do what you do. And we just wish you the best of luck and success with your career.
Thank you.
Thank you for listening to the Healthful Woman podcast. To learn more about our podcast, please visit our website at www.healthfulwoman.com. That's HEALTHFULWOMAN.com. If you have any questions about this podcast or any other topic you would like us to address, please feel free to email us at hw@healthfulwoman.com. Have a great day. The information discussed in Healthful Woman is intended for educational uses only and does not replace medical care from your physician. Healthful Woman is meant to expand your knowledge of women's health and does not replace ongoing care from your regular physician or gynecologist. We encourage you to speak with your doctor about specific diagnoses and treatment options for an effective treatment plan.